I think there's a lot of interesting stuff in there. So, my approach here is really to give you the information about the sort of major um, cancer screenings. I'm including though the DEXA. I'm going to talk about that. Um, the less frequently used tests. I mean, there are just so many that it would be really hard to get to all those in one presentation. But if people have questions about things like cholesterol, pre-diabetes, those topics at the end, I'm certainly happy to talk about that. And maybe we can talk about it as a group and, but I certainly do a lot of that in my work. But I didn't really bring those into this discussion per se, but I'm happy to, answer whatever questions at the end. Okay, well, now we have somebody who can actually share their screen. So we'll just, I think I was, so you're going to be forwarding the slides?
I will.
Okay.
Yep. So just let
So
me know. Say go for
Okay,
it.
so so next slide.
Okay. There we go.
So and I kind of talked about that too, actually. So I think we had just finished that slide when but maybe people didn't see it, but I did talk about it. And I was here, yep, so here we are. So so the question is like, why do we talk about this? Why is this important? And the purpose of cancer and health screenings is to detect a problem before symptoms appear. So when it's most treatable and sometimes even preventable. Some of these screenings actually find precancerous conditions, and then the treatment is much more minimal than it would be had it been found much later in a later stage. So, it makes treatment more effective, likely less aggressive, and also the survival rate is higher. Next slide. So the screenings that we're going to cover, and then again, we can talk about some other things at the end, but more specifically are cervical cancer screenings, breast cancer, the mammogram, ultrasound, MRI, and how those each come into play at different times, colon cancer screenings, the colonoscopy, the fecal occult blood test, which is often referred to as the FOBT, the Cologuard, and then this new test, the Shield DNA blood test, which was just approved by the FDA in 2024. The lung cancer screening for those with a particular smoking history. And although there we may not have any longtime smokers in the group, you may know somebody who does. So I think that's a really important one. And then finally, the bone density, the DEXA, which is the dual energy X-ray absorptiometry, which is why we call it the DEXA, because nobody can pronounce that. Um, so starting with the cervical cancer screening, and that's really just the pap smear. The pap smear is a screening test that can detect early changes in the cells of the cervix that can lead to cancer. It detects precancerous cell changes in early cervical cancer. Cervical cancer, like actually some of these cancers that we're talking about today, are slow growing. So the PAP can really detect changes years before these cells become cancer. Um, Cervical cancer is often caused by the HPV virus. That is the main cause of cervical cancer. This is a sexually transmitted virus, and it can be detected with the pap smear. The pap is not a screening test for uterine or ovarian cancers. Sometimes people sort of lump all the reproductive organs together with the pap smear, but unfortunately it's not. I wish we had screenings for those, but we don't. Um, so it's just for the cervix. Next slide. The ACOG is the American Congress of Obstetricians and Gynecologists, and this is a table of their recommendations. So it used to be that we started getting pap smears at age 18. Now it's 21. And the reason being that a lot of these young people who have maybe HPV or they be test positive for those things clear very quickly in the young. So 21, it's been moved to 21 years old. And starting at 21, they recommend just doing cytology alone. So they're not checking for HPV as well. They're just checking the cells every 3 years. And again, that's because HPV is really common in the 20s and it often clears up without any intervention. Um, Starting at age 29 to 65, the ACOG says you can do any one of these three options, cytology only for every 3 years, HPV testing alone every 5 years, or co-testing, which is both cytology and HPV every 5 years. I have never worked anywhere where we offered the other two. I've always done the co-testing. I mean, at Smith with the younger crowd, I do the cytology every 3 years, but for older patients, um, almost always they do the co-testing, but every once in a while you'll hear of the others. And then greater than 65, if you've had 10 years of negative co-testing, so that means, or negative testing in general, but 10 years of negative co-testing would be your last two co-tests were negative. So that means negative for cancer cells, negative for HPV. And if you have that for the last 10 years, then you can stop getting pap smears. Um, if not, then you would need to continue longer. Exceptions to this, people who would need more frequent screening um, are people with a history of cervical cancer, people who are HIV positive, people who have a weakened immune system. And then there's a small population of people who are exposed to something called DES, which is a hormone given to pregnant women during the 40s through the 60s. So those people as well. If you've had a total hysterectomy, and by total, that means you've had your cervix removed, then you do not need to be tested for cervical cancer. So that population does not need screening any longer. So just making sense of pap smear results, there's several possible results after having a pap smear and your provider. I'm not going to go into each one because it's time consuming and probably not beneficial, and your provider would go over it with you. A normal result is labeled NILM, which means negative for precancerous cells, and HPV negative. If it's abnormal, you're often recommended in most cases, I would say, to repeat it in 6 months, a year, sooner than the 5 year interval. Um, unless certain results it would be recommended that you have something called a colposcopy, which is a biopsy of some of the tissue from the cervix. Talking about prevention, the HPV vaccine has lowered the rates of HPV significantly, up to 99% when all the shots are given. So that has had a huge impact, that vaccine, on the number of women getting cervical cancer. Any questions about cervical cancer screening?
I have a question.
Sure.
Regarding the recommendations over 65, do you believe that in a DES exposed person that the recommendations of, it's difficult to get a negative result when you're DES exposed. So if you can maintain a, baseline abnormal, which in my
Right.
case, you know what I mean? So if that were stable for 10 years
Mhm.
in a row, or, repeatedly over 10 years,
Mhm.
could you decrease frequency of screening after 65?
I would think so, but again, I can't answer that for sure.
Okay.
I think that stability is always a good sign when we're looking for cancer. We cancer changes and grows, and so often these screenings are about stability. So it's a really good question. I would think that there could be, fewer or longer interval, but you would have to ask your provider specifically about that.
That's fair. On a related note, though, do you believe or do you have evidence that women in their 60s and 70s and older are still prone, if they're DES exposed, still prone to cervical cancer? Have you seen
I have
diagnoses
not
after that
seen that.
age?
I have not seen that. So I don't
Okay.
have personal experience with that.
Yeah.
But I do have patients in their 60s and 70s who still want to get pap smears. And for whatever reason, I know why, but they do. And you have to respect, and so they can, that's
Yeah.
their right. And in many cases, probably not all, unfortunately, but insurance covers it. Um, but I don't know about that specifically. I'm sorry.
That's okay. Thank you.
Anything else? Okay, so moving on to breast cancer screenings. So we're going to talk about the mammogram, the ultrasound, and the MRI. And it used to be that we really just relied solely on the mammogram, but now these three are being used often in concert with each other, um, depending on the situation. So here are mammogram recommendations. I've put up two different recommendations, although they're very similar. If they end up being quite similar. The one of them is the USPTF, which is the United States Preventative Task Force. And I've put all the websites at the end of this that I drew information from. Um, and they're all really good websites to get research-based information, health information. And then the other one again is ACOG, which we talked about before. So they're starting mammograms now at 40 for average risk women. So this is not for high risk women, and we'll talk about what makes someone high risk in a minute. Um, age 40 to 74. And the United States Preventive Task Force says biennial screening, so every other year screening, whereas ACOG says every 1 to 2 years. And I really leave that to the patient and maybe guide them a little bit if they have a certain family history or very dense breasts or something like that. I might say, you might really want to go with 1 year. But it's really up to the patient how comfortable. Some people aren't comfortable getting radiation that often. Um, and they really just do not want to do it every year. So that's fine. Um, and women 75 and older. So again, I have patients in their 80s still getting mammograms. But the USPTF says that there's really not enough evidence to sort of determine the harms and versus benefits of screening mammograms for women over 75. ACOG puts it a slightly different way by saying they can stop or continue until your life expectancy is less than 10 years. Well, nobody really knows. But if I have an 85-year-old person in front of me and they are active and healthy and, cognitively alert and, and they are okay with getting another mammogram, I might say, yeah, you should still be getting mammograms. I mean, you may be around for another 15 years, and if that's what you want. But again, you have to talk it through with your patient and with your provider and decide. And then there's this whole question of women with dense breasts. And I always kind of chuckle because I think every other mammogram report I get says the woman has dense breasts. But so the mammogram report will state what your risk is based on the density of your breasts. And I'll talk a little bit about that risk profile later. But so some women have very dense breasts, and the MRI is not going to necessarily pick something up. And so they do often now have the option of getting a MRI and or ultrasounds for screenings. And again, that is determined by a breast specialist. But that can be very beneficial. And then ACOG pretty much says the same thing. But again, the United States Preventive Task Force says, well, we don't really know for sure. So they're just a little more cautious about it. So the MRI. So the MRI of the breast is magnetic resonance imaging. It finds breast cancer. It can find breast cancer. Whereas the mammogram kind of will say, oh, there's a change over here. There's something suspicious over here. But the MRI can really determine whether something looks cancerous or not. It takes pictures of the inside of the breast, and there's no radiation. The breast MRI might be done after a biopsy shows cancer. It can be done to show the extent of cancer. Again, if someone has dense breasts or maybe a very strong family history, they may get an MRI. The thing about the MRI that's tricky is that it's very expensive. So you do need to have some kind of medical justification, usually, to have it covered by your insurance. So these women that are higher risk, so we all know about, genetic mutations. We hear a lot about BRCA1, BRCA2, a family history, especially first degree relatives. If you have a mother and a sister who both had breast cancer, a 20% plus lifetime risk. And that value is calculated by something called the Tyrr-Cuzick model, which is basically a formula that they put different information in, and it comes up with a percentage of your lifetime risk. If you're any of these things, then you should begin. It says 25 to 30 here, and actually, I should have changed that because I think it can really happen at any age. I don't think it is limited to 25 to 30. But if you're going into 25 and you have these risks, then yes, you should start at 25. Again, for women with dense breasts, some supplemental imaging might be recommended. And then again, this is, just more about the family history. You have a breast cancer gene that you've inherited. The MRI is often used. The ultrasound is more often used if there's something seen on a mammogram that's questionable, that's localized. They will maybe follow up with an ultrasound to get a closer look at it. It's an easier test. It's a less expensive test. Also, if if a woman feels a lump in her breast that's new, or the provider does, then they would order an ultrasound. I have people come in and say, oh, I feel a lump in my breast that wasn't there before. And really, honestly, whether I do or don't feel it, I usually get an ultrasound because, the physical exam is not always so great. So oftentimes if a patient feels convinced they have a new lump, I'll order an ultrasound. Any questions about breast cancer screening? Okay. Colon cancer screenings. Okay, so I mentioned these before. These are the ones we're going to talk about individually. We can just go to the next slide, Lizzie. Thank you. So the colonoscopy allows the doctor to look inside your large intestine, colon and rectum, and check for problems. They look for polyps, they look for hemorrhoids, they look for diverticulosis. But as a cancer screening tool, they're really looking for polyps, which are small growths that can turn into cancer. They use this long, thin, flexible tube with a little camera on the end, and they can see the images in real time as they're doing the test. The patient must follow a special liquid diet and take a bowel cleansing solution in approximately 24 hours prior to the procedure. The patient's sedated and they really don't feel any pain. The whole procedure takes about 20 to 45 minutes total. The reduction in lifetime risk of colorectal cancer using the colonoscopy is 73%, and the reduction in risk of death by colorectal cancer is 84%. So that's pretty significant. So the colonoscopy results, so usually, if they find polyps, they're going to take them out. They're going to test them. If they're precancerous, then they will recommend that you follow up in anywhere from usually 3 to 5 years. I have 3 to 7, but it's usually 3 to 5 years. If you have a normal colonoscopy, no polyps, then they're going to recommend you repeat it in 7 to 10 years. It used to be pretty much solidly 10 years. I'm noticing now that they're more frequently saying 7 years. Colonoscopies are now starting. I actually left this out, but they're now starting at the age of 45. So that age is getting younger too. We're seeing more colon cancer in younger people now. And also, again, your family history, your personal history regarding colon cancer and precancerous polyps goes into the decision of how soon you start the test. If you have a first-degree relative who, say, got colon cancer at the age of 55, it's going to be recommended that you start colonoscopies at 45. If they had it at 45, you start at 35. And that's because if you are genetically, at high risk, then if they catch it that 10 years before your relative got it, chances are they're going to prevent it from becoming cancer, or, it'll be minimal, much more minimal treatment needed. So the fecal occult blood test is a stool sample, and they simply check for blood in your stool. Blood in your stool, and I say this to patients all the time because I don't want them to freak out if they get a positive result, but it can come from a lot of things. It can come from hemorrhoids, it could come from fissures. It doesn't mean the person has cancer. However, if they get a positive result and they find blood in the stool, then you're going to be recommended to see a gastroenterologist, and you'll probably get a colonoscopy. The result of this test is good for 1 year. So if a patient chooses to do this, they don't want a colonoscopy, they never want to get a colonoscopy, and we'll talk about the reasons in a minute, but if you do this every year consistently, this test, then you see at the bottom of the slide, the reduction in risk of getting colorectal cancer is 52%, and of death from colorectal cancer is 73%. So this is a pretty effective test. But the trick is you really have to do it consistently every year. And it's not an expensive test. I think it's about $25 or so. So a lot of patients do choose this test if they don't want to do a colonoscopy. And they can do it in their home, and it's pretty simple. The Cologuard is another stool test, like the fecal occult blood test. the difference is it doesn't just look for blood. It also looks for some DNA markers in your stool that could indicate cancer or precancerous polyps. This is ordered by your provider. You get it mailed to you from a separate company. They mail the kit to you. You mail the sample back, and then they send you a result. Again, if it's positive, they're gonna recommend you go see a gastroenterologist and probably have a colonoscopy. This test is good for 3 years if you have a negative result. So longer than the fecal occult blood test. However, of all the tests that right now, although we can't speak for the newest test yet, but for the ones we've talked about so far, the Cologuard is the least effective in catching early signs of cancer. So the reduction in lifetime risk is the lowest of the three we've discussed. 46% for lifetime risk of the cancer, and from death, 66%. So that's just something to think about. It's not that it doesn't have any use, but it is the least effective in as far as the research has gone. So this is the new test, and honestly, I've never ordered this test. But I just thought we should include it because there's probably going to be more out there about it. It's a blood test. And so it's a blood test you could just have in your provider's office. It looks for DNA changes and fragmentation patterns that may indicate cancer. Your results are either negative or positive. Again, if it's positive, they're going to recommend you get a colonoscopy. If negative, it's good for 3 years, like the Cologuard. However, this test is not yet covered by insurance and it costs $900. So it's expensive. And there's really not enough research yet on the percentage, the reduction of lifetime risk. So there's more. I'm sure we're going to hear more about this test. And so these are I put cons before pros. Don't ask me why. Usually we put pros before cons, but so this is just really the pros and cons of these 4 tests. So the colonoscopy, you've got the bowel prep, which is not fun. It's challenging and kind of miserable. Sedation is needed, and it's an invasive procedure. Those are the reasons people usually choose, if they don't want a colonoscopy, that's pretty much why. However, the pros are that the negative result is good for 10 years, and it has the highest reduction in lifetime risk of colorectal cancer or death from colorectal cancer. So it's a very, very good test. It's really considered the gold standard, but it is sometimes hard to convince people to get it. The fecal occult blood test, the cons are it has to be repeated every year, and if positive, you have to get a colonoscopy. The pros are it's inexpensive, no bowel prep, no sedation, non-invasive. Cologuard, it's also expensive, but I've had pretty good luck having it covered for people, but I can't speak for everybody's insurance. And it's less effective than the other tests in preventing colon cancer death. But again, like the other tests, there's no bowel prep, no sedation, it's non-invasive, you can do it at home. And then the newer test is also very expensive, and it has done poorly in studies in detecting precancerous polyps. Questions about colon cancer screening? Okay.
I have one.
Yes.
This is maybe a foolish question given the results from Cologuard that you cited, but I am curious about the correlation between colonoscopy results, subsequent colonoscopy results that are forced by a positive Cologuard test. Like, how often do you see the colonoscopy standing up to that Cologuard result?
That's a really good question, and often the colonoscopy will be negative. So, and certainly not showing colon cancer. I mean, a lot of people have polyps. So, then the recommendation is often depending on what the biopsy results are of those polyps. Um, but the same thing happens with the fecal occult blood test, that, we send people to gastroenterology, they get a colonoscopy, and they're fine. They
Yeah.
don't have cancer. So, I think the question I think it's just in terms of, I mean, I'm working in an isolated little bubble. I think when you look at the bigger picture and over someone's lifetime, um, I think if you were to compare regular Cologuard use with regular colonoscopies, that's where the difference lies in terms of survival or not getting
Mhm.
cancer. But oftentimes you're right. I mean, the resulting colonoscopy, and sometimes you send them and they have a discussion um, with the gastroenterologist, and sometimes the gastroenterologist doesn't even order a colonoscopy, interestingly, especially with the fecal occult blood test, because they determine it's from some other source. Um,
Okay.
so yeah, it's by no means a perfect
Right.
science.
Thank you.
Yeah.
I have a question on if you get a colonoscopy and it's okay, why is it 10 years? I feel like cancers like grow and spread so fast that a lot can happen in 10 years.
So if you have a colon, I mean, I'm sure there's this over after years and years of research on this, but if you have a colonoscopy that is completely normal, the lining of your colon is completely normal, there are no polyps, um, or they remove one little polyp and it's not at all precancerous. Um, the risk of you getting colon cancer or having precancerous polyps in the following 10 years and that actually developing into a cancer is extremely low. Actually, colon cancer is not a very fast growing cancer. It's a rather slow growing cancer. So the problem is a lot of people just, they're very genetically inclined to getting it, and that's very unfortunate, or they just haven't done any screening. Um, so it's not there are very fast growing cancers out there. Colon cancer isn't one of them. So I think that research has suggested that if you have a completely normal one, and like I said, they're actually dropping back to 7 years now more often than 10. So does that answer your question? Yeah.
Yes, thank you.
Mm-hmm. All right, lung cancer screening for smokers. And this is done with the low dose CT scan. So lung cancer is the leading cause of death, of cancer deaths, sorry. And for 2026, it's projected that we'll have well over 200,000 new cases and well over 100,000 deaths from lung cancer. Smoking causes 80 to 90% of these cases. There are people who get lung cancer that have never smoked, but most cases are from smoking. Um, so those considered high risk, and again, this criteria has been recently adjusted, include people ages 50 to 80 years of age with a 20 or higher pack year history. So we talk about pack years in cigarette smokers. And really what you're doing is you're multiplying the number of packs, even if it's half a pack, whatever, that they smoke a day times the number of years they've been smoking that much. So someone who smokes a pack a day for 20 years is a 20 pack year history. Someone who smokes 2 packs a day for 10 years has a 20 pack year history. And they have to have either they currently smoke or they've quit within the last 15 years. So someone who quit 20 years ago does not qualify for a low dose CT scan. Um, if lung cancer is caught at an early stage, the 5-year survival rate is 5 times higher than it would be if it's caught at a later stage. So this really does save lives. And I've seen people get positive CT scans, have a biopsy, it's cancer, and they live to talk about it and tell the tale. So it's a really important scan for smokers. Um, and yeah, so I think that's it for that slide. So it's the low dose CT scan, and there's no preparation for this. There are no needles, nothing. It's a 5-minute test at the most. It uses low dose radiation. The radiologist reads the result, and gives the scan a risk category level. What they're looking for are nodules. I think of nodules as sort of the equivalent of the colon polyps. They can be nothing or they can be something. And they're small spots in the lungs, and they're usually from, again, other things, causes than cancer. But it could also be cancer. So usually with the low dose CT scan, if they think that the nodules are likely benign, meaning not cancer, they will recommend that they follow up with a repeat scan in sometimes 6 months, but it's usually a year. And what they're doing is checking for stability. So if that nodule does not change over 3, 5 years, they're pretty sure it's not cancer. But if it does start to change, then they probably will recommend a biopsy. And if you have a normal scan, they recommend you can repeat it. You can repeat it every year if you want, actually, even if you have a normal scan. So benign nodules that aren't cancer, are from prior infection, acid reflux, inflammation, some autoimmune disorders like rheumatoid arthritis, scarring from past smoking or pollution exposure. Um, and then that sort of repeats what I just said about, it's important to watch the nodules, because if they change, then that's possibly cancer. But oftentimes they just stay the same over many years. And then I put my little plug in there at the end for quitting smoking. Because one of the best things you can do is to lower your risk is to quit smoking.
Mary, I just have a quick question. I was reading in Japan, does a lot more lung cancer screening than the US, is what I was
Hmm.
reading about. And unfortunately, my uncle just died of lung cancer in December, and
Hmm.
he was
Sorry.
79 and he smoked like in his early 20s, but hadn't beyond that. And so,
Wow.
um, I just it's interesting that Japan is so much stronger in their lung cancer screening than the US, and they
Hmm.
find it so much earlier that I just wonder if that recommendation won't change in the future based on um, like
Yeah.
more screening beyond just that very tight bubble of when you last smoked kind of thing.
Yeah. Yeah. Well, based on your uncle's experience, and I'm sure there are others like that, I wouldn't be surprised. And they've lowered the age for colon cancer, breast cancer, so I think that we're finding cancers in younger people more and more, and that these screenings are really helping to catch things early. I think it always, and unfortunately, and I don't know what the health insurance world of Japan is like, but so often this is about what your insurance will cover. So if a 30-year-old or somebody who's 70 who quit smoking more than 15 years ago, they want a CT scan, they can get one, but they're going to have to pay for it. So that's really what it boils down to. So I hope they do, because I think that we'd see even, we'd catch even more cancers. But I don't know why that's different and why we're so different than Japan. Um,
Yeah,
That's
what?
interesting. I'll have to read about that.
Yeah. The New York Times did a great article on it. But one other question I had, is there any downfall to getting a CAT? I mean, not that I want to get one, but like if there was any, is there any risk to getting a CAT scan?
I
Um,
mean, there's radiation.
uh-huh.
It's low dose radiation. Um, I think that people have their degree of tolerance for exposing themselves to radiation, people there, and it really runs the gambit. So I don't think I don't think there is a risk, no. But because I think the radiation is low dose, and I think if you're doing it, you know, periodically based on the recommendation, I think the benefit far outweighs the risk. And that's what it's all about always, is weighing the risks and the benefits. Because there's risk to everything,
Yeah, thank you.
but I think the risk is very small.
And I'll just hop in and say, welcome to, we've had a couple of late comers. I see we've had Diane and Carrie join us. Just to let you know, we are recording this, and so you will be able to go back and watch the program from the beginning too, if you would like to after the fact.
So next slide, I think we're ready for. So I think we did the questions for that, unless somebody else has a question.
I mean, I guess I think maybe I do. Maybe it's sort of similar to Sasha's question that, I think a lot of us have people in our lives who have kicked a smoking habit, many years ago, and that seems it feels like they exist in kind of a gray area a little bit in terms
Mm-hmm.
of like how you could advocate for yourself at your
Mm-hmm.
providers. Is that that's something that you should be talking to your provider, but can your provider say, well, since you did, you smoked for whatever, 5, 10 years in your teens and 20s, it might be a good idea, or is that just like you'll be paying out of pocket because it's not,
Yeah,
you
I
know,
think out of fairness, I mean, providers can't really tell you what you're going to pay for anything they order, because we know very little about insurance, to be quite frank. I mean, and so, I don't know exactly what plan they have. I don't know the specifics of it. So I often will say, I'll order it for you. And I think it's reasonable that you want this, but I would contact your insurance company, and to be honest too, between, all of us, I have actually fudged the numbers a little bit for people. And I mean, not that much, not if they quit back when they were 20 and they're now 70, but if it's a matter of a few pack years, I will manipulate the numbers enough so that I can get them to qualify for it. But
great.
I mean, yeah. So yeah, I agree. I think it's not, again, it's not perfect, and I wish that we lived in a system where people could, determine their own care and get the health coverage for it, but we don't, unfortunately. Yeah.
Mm, great. Thanks, Mary.
So the bone density scan. So this is the only non-cancer screening that we're talking about, but a really important one for women. And I know, I think maybe it was Nicole, or no, somebody was interested, especially in this. So this scan, we refer to as the DEXA. And so we talk a little bit about osteoporosis and, bone health. So when a woman goes through menopause, whenever that may be, she has less estrogen circulating um, in her body. And so estrogen helps prevent bones from getting weaker by slowing the natural breakdown of bone. So during menopause and after menopause, the bone loss rate significantly speeds up. Um, So there's osteoporosis, which is, significantly porous bones, which is what osteoporosis means. Osteopenia is low bone density, but not yet osteoporosis. Next slide. Here, right here. So bone health, and why is it so important? Why do we even care? Well, because as we all know, because we have older people in our lives, um, as we get older, we have a much higher risk of falling. And if we're falling, we have a much higher risk of breaking bones. Each year, there are 3 million emergency department visits due to older people falls. In 2019, 83% of hip fracture deaths and 88% of emergency department visits and hospitalizations for hip fractures were caused by falls. Bone fractures, especially in older adults, significantly increase mortality risk. So if you think about it, an older person breaks a bone and they cannot be as mobile for a long time. And they become deconditioned maybe. They're more at risk then of infection, of getting sick. It's sort of a snowball effect. A young person breaks a bone, they heal much quicker, they bounce back much quicker. So fragility fractures often signal a decline in overall health, if not mortality, with risks remaining elevated for about 10 years, up to 10 years. So the DEXA uses radiation, again, to measure how much calcium and other minerals are in a specific area of your bone. It's a 6-minute, low radiation, painless, and non-invasive test. Because the weak bones that tend to break most often are the hip and spine, the DEXA usually measures the bone mineral in these bones. They often also will do the femur bone, the head of the femur. So the results are referred to as a T-score, and it's basically comparing your density, your bone density, to that of a healthy young person with healthy bone density. And if theirs is 0, if their score is 0, then the T-score goes from there down as the bone density decreases. So normal bone density T-score is -1 or higher. Osteopenia, which is not yet osteoporosis, is -1 to -1 to -2.5. And osteoporosis is less than -2.5. They rate each bone that they look at. So you might be osteopenic in your hip bone, but have osteoporosis in your spine. It can be different. But you do have to kind of pay attention to the one that's the worst in a way, because, that's where you're most vulnerable. So again, we have the task force recommendations for screening. So the screening is women 65 years and older. They recommend you start at 65. And then but the exceptions are if you're younger than 65, and you have one or more risk factor. So risk factors are a lot of things. There's several things it could be, but I just gave a few examples. Long-term use of steroid medication. Some people are on long-term use of like prednisone for certain autoimmune disorders, or organ transplant, or polymyalgia rheumatica, something where they have to take prednisone for a long time, that depletes your bone density. Unexplained fractures. If you have somebody who hits their arm on a table and breaks their arm, or has a very, very mild accident and breaks a bone, you might think, maybe we should check their bone density. Early menopause. So some people go through menopause a lot earlier, earlier than the average, which is about 50, 51. So if you go through menopause at 40, then you're going to need to start bone density screenings earlier than 65. Questions about this, and we can talk about, prevention and that kind of thing too.
Mary, I was wondering if there's any research done on using hormone replacement therapy or HRT in terms of normalizing or increasing bone density. I'm sure this is a really common.
Absolutely. Absolutely. Yes. Hormone replacement therapy is in a heyday right now. It can be very helpful in not replenishing bone so much as, but just helping prevent bone loss in postmenopausal women or perimenopausal women too. The HRT, in my mother's day was somewhat popular. And then there was this research done and a report published that came out saying that, this puts people at very high risk for breast cancer and all kinds of other cancers, and we shouldn't be giving this to women. And now, more recently, probably in the last 5 to 7 years, maybe, there's been that research has actually been found to be false and inaccurate, and that there's a lot of benefits to hormone replacement therapy for some women, not all women, but and bone density is one of the benefits for sure. The other benefits are it helps with menopausal symptoms. It even shows some evidence that it could help prevent or stave off dementia. Yeah.
Sign us up. No.
What?
I said, sign us up. No, just
Yeah, exactly, right? I know.
have
This
you
includes the,
oh, go ahead, Aura.
I was just going to clarify, this includes the patches.
Yes.
My daughters are on these patches and not available when I was going through it, but
Yeah.
so very good.
Patches, and the only caveat about it is if you still have a uterus, you also need to supplement with progesterone, so that you don't have a risk of uterine cancer. So if people don't have a uterus, then they can just do estrogen, but if they do, then they should also take progesterone.
Hey, Mary, have you ever read the studies? I think they're like NIH studies. A friend of mine who's a doctor hadn't really believed it, but someone had suggested they had read about prunes, and she did the research and found out that prunes actually have had, I think if they have like 6 a day, maybe, but there's something in them that is very beneficial for bone density.
I have not heard that, but
Yeah, it's like one of those
look it
things you're
up.
like, oh, that sounds quacky, but then there's real studies that have
Yeah.
been done, and I'm like, that's a pretty non-invasive thing to have to do. So I'm like, yeah, if it works
Absolutely.
for me, I'm like, all right.
So talking about prevention for bone density, and I talk about this with the college students I work with, because I think, again, the sooner you start, the better. But so the 3 things we talk about with bone density, and I'm sure some of you have heard this from your medical provider, but is vitamin D, which we get from the sun, and especially those of us in New England, we don't get much sun. And so supplementing with vitamin D daily, getting your vitamin D level checked. It really should be, in my opinion, over 40, the number. I think anything under 30 is considered, abnormal, but and taking a supplement of vitamin D is easy to do. You don't have to worry about the quality of it. The research does show that D3 is more absorbed better by the body than D2 for some reason. But anyway, so vitamin D, calcium, which really should come mostly from your diet. But if you feel like, oh, there's no way I'm getting enough calcium in my diet, then you could supplement as well. It's better than not doing it. And weight-bearing exercise. Those 3 things are the most important thing for bone health. So, and even if you have osteopenia, I mean that, and or osteoporosis for that matter. To prevent further loss, those things are recommended. If you have osteoporosis, then there are medications that are available to help reverse the bone loss to some extent. Um, and the group of medications that your primary care provider could probably prescribe without an endocrinologist in most cases are the biophosphonates. And then there are some newfangled ones, injections, infusions, that you could do that you're really would be prescribed by an endocrinologist.
Mary, just a quick
Yeah,
question.
okay.
What's the dosage that you recommend for D3?
So, so there is something, there is vitamin D toxicity. It's a real thing, but you do have to take extremely high doses to become toxic, for it to be toxic. I usually, if someone has normal D levels, then I recommend like anywhere from 800 to 1,000 units a day. Taking 2,000 units a day is fine. If somebody is very deficient in D, they're treated with a high dose, which is 50,000 units a week, for about 8 weeks, and then we recheck it. But for the average person, I'd say 1,000 units a day is adequate.
And Mary, so I don't remember what the level was, but my vitamin D was low, and so my doctor recommended taking vitamin D, and there was no change. It didn't help the
Huh.
first year when I took it, but when I started taking it I took it with a fish oil tablet to take it with oil, because I guess your body, the fat has to encapsulate actually the vitamin
Mhm.
D. So I'm just wondering, like, maybe because whatever I was eating didn't have, and when I took it, I'm assuming
Mhm.
there must be some time frame that you need to have that fat with the vitamin D before it goes into your body but doesn't get utilized.
Well,
And I
it's a
was
fat
wondering,
soluble vitamin, so that does make a lot of sense. Yeah.
yeah, but it
Yeah.
really, yeah. And then the next year when I was tested again, it was fine. And that was the only change that I could think of that I
Yeah,
had
I'm
done.
learning so much just
Yeah.
this.
But I also
Yeah, that makes
wondered,
a
like,
lot of
in that
sense.
year when I was taking vitamin D and it wasn't
Absorbing.
changing my
Yeah.
levels, like,
Yeah.
doesn't that end up sort of accumulating in my body? Or, I mean, seems odd that it's like, where did it go if my body didn't use it?
Well, yeah, that's a good question. I'm sure your body metabolized it in one way or another. I mean, if your level wasn't a toxic level, then you're fine, right? I mean,
I guess, I don't
it
know.
would have shown in your blood work.
Okay,
So
yeah.
yeah, it would have shown in your blood work.
Anyway, so yeah, but the
Yeah.
more I read, I'm like always like, oh, well, maybe that would work. So anyway, that did help my levels, just making sure that I took them at the same time. Yeah.
Yeah, yeah. Well, that's really good advice. Yeah, most people, I don't find that. I find, especially with those high doses, it pops right up, but
Well, I didn't
it
take
goes
like the
right back down. Then
50,000.
people
Yeah.
stop taking it. We just don't get much sun here.
Yeah.
That's how we get there's very little vitamin D in our diet. There are very few foods that have enough D. So it's really primarily from the sun.
I did read also that mushrooms, if you put them
Yes.
out in the sun, they absorb that vitamin D, and so you then eat them, you get extra vitamin D.
I've heard that mushrooms are yeah, they're a good food for D.
Go figure. But stick them in the
I
sun
eat a
so they
lot
can
of
absorb.
mushrooms though, yeah.
Yeah.
Yeah. Any other questions? It doesn't have to be related to, anything else that people wanted to talk about?
Sticking with the bone density topic, I'm interested in other means for tracking either like the markers that show bone turnover in the absence of, well, I don't have a current DEXA scan. That would be a good place to start. But what I'm struggling with is the fact that DEXA isn't recommended until you're 65, and yet we know that estrogen receptors are declining by your late 30s, early 40s, and people are already kind of set up by the time they're 65. If you don't know you have a bone density problem, it's very late in the game to be fixing it, when you could be in a more preventative mindset. If you knew, like, in your 40s or even 50 would be awesome. And I suppose you could make a case for getting a scan, but in the absence of family history. So
Right.
what's your opinion about that?
You can make a case for getting a scan earlier, and we often do for whatever reason, if um and patients often do want to get them earlier, and I think it's one of the easier tests to argue for. You could say early menopause, I'm saying your provider would have to, right? That it's all about, I hate to say this, but this is reality. It's all about the
Insurance.
diagnosis that is given to the order. So,
Right.
so you need, it's kind of on your provider, and some providers, we all have our comfort level with this. And I'm comfortable with bending the rules a little bit, and in a way that I won't get in much trouble but some people are just much more bold about it, and some people really stick to the rules. So it just really depends. But someone could argue like, oh, she had early menopause because she went through menopause at 47 instead of 50, or there are ways to get an earlier scan. I think that's one of the easier ones to get earlier and have it covered.
Mm-hmm.
So, have you talked to see, I'm not going to get personal, but yeah,
Sure, there are ways to do it. I guess I'm struggling with the fact that the recommendation is still 65 years old when we know that this is one of the highest rates. Yeah.
No, I think everybody, why aren't we scanning people at 45, and then, maybe if they're normal again at 50, 55. Yeah. But in the meantime, all women, all ages should be really thinking about height loss. Yeah, that's another good one. Losing height, that's a good indication of osteoporosis, and a significant amount. I think we all shrink a little bit, yeah. So, but again, for all women, all ages, the vitamin D, the calcium, and the weight-bearing exercise is really crucial. And interestingly, very, very thin women tend to get osteoporosis more readily than less very thin women.
Okay.
Yeah.
I was wondering if you've heard any research about what they're calling like the J curve. So women whose BMI is like right on the edge or a little bit overweight actually have a higher chance, like being a little overweight when you're older actually helps, is actually more healthy than being thinner because of bone density along with other things.
Yes. So, and I don't know all of the factors I don't know if they even know what all the factors are, but there's been a lot of research recently about how women, and the BMI is such a poor assessment tool, but we do use it all the time, unfortunately, still. But a BMI of right, like there's something like BMI of 25 to 28 or something in there. The women tend to have better outcomes and live longer and be healthier in their old age than women with BMIs of 20. And you could come up with a lottery. Bone density certainly is one of them. And I think also you just think about reserves too as you go into your old age. And if you get sick and you weigh 90 pounds, I think you're going to have a much harder time than if if your BMI is higher. And having those sort of energy reserves. So there is this window in there that I think is yeah, we're learning that it's actually very has better outcomes.
Thanks. Yeah.
Mary, I think that there's sort of like an interesting, yeah, it's interesting. I think that you are talking about a lot of these screenings where, the minimum age is much older, yet you work with younger women, at Smith, and I think it just makes me wonder, I think you've touched on that a little bit with, getting calcium, getting enough vitamin D, weight-bearing exercise, but is there anything that you would say or is there anything that you feel is really important to kind of bring into these visits with younger women as they're thinking about, this is probably a big question.
It is a very big question. There's so many things they need help with. So yeah, I mean, it just depends on what we're talking about in the moment. But I do talk to them a lot about pap smears, because they're 21 is the recommended age to start. And so we start having that conversation. I talk to them about the vitamin D, the calcium, the weight-bearing exercise, and I think for all my patients, really, I mean, unless they, are for whatever reason not able to be physically active, I think learning, well, it's tricky with women, young women, and at a college like Smith, because you get talking too much about diet and exercise, and the focus becomes about weight, which is never what I'm talking about when I talk about diet and exercise. But so it's a kind of a little balance you have to keep. But really, like, sort of developing a mentality of healthy diet and some kind of regular exercise for overall health, mental health too, and so I really try to broach that, and especially too, if I have a young patient at my other setting, Valley Medical Group, if I have an obese 22-year-old guy, um, you know, I'll talk to him about, you're young, you've got your whole life ahead of you, and you really need to start thinking about the kind of life you want to have. And, I get a little more heavy-handed maybe, but, you know, helping them understand the things that, can keep them healthy for longer. And some of that is cancer screening. Some of that is checking your cholesterol and checking your blood sugar and getting your pap smear. And, I do think these screenings aren't perfect, and the recommendations aren't perfect, but they do save lives. And so I think that, and I understand why people don't want to get them sometimes, and I would never call somebody out on that. But I think that, just helping people sort of get all these messages gradually over time, if you have that time with them. Um, yeah.
Awesome. Thank you.
Yeah, I don't know if
Well,
I
I'm just
really answered
broadly
your
asking
question. I
you.
kind of went off on a tangent. I don't know if I answered your question.
No, that was a big question. How does everyone live the healthiest life possible from the youngest possible age?
Yeah, yeah. Well, the college I work at is a lot of very, I actually do a surprising amount of mental health, at the college, as a primary care provider. Um, that's probably at least 50% of what I do there. So that's a whole other topic. But yeah.
I was going to put a word in for bone builders. We're at capacity right now, but there's a wait list and get on it because it's really a terrific program. It's right at Whirl. It's free, and it does all the weight bearing things that Tufts University said were great things to do. So I can't recommend it enough.
That's great.
Wonderful. Thanks, Aura.
Well, I thank you all for putting up with this long, long, wordy presentation. And I hope it was helpful. And I hope if it, you know, didn't help you directly, that maybe, you can pass something on to a loved one that would be helpful to them.
Thank you, Mary, very much. Thank
Yeah.
you.
Yeah, thank you so much. It was great.
Yeah.
Good night, everyone.
Bye.
Have a great
Thank
night, everyone.
you.
Thank you for coming.
Good night.
Thank
Thanks,
you.
Lizzie.